Hello and welcome everyone. Dysphagia in patients who are extubated is something which we rarely put our minds into regularly in our ICUs or in our rounds. Now, why should we actually start caring about it? That is the first thing we need to understand. Uh, Around 1 out of 5 emergency ICU patients, they go on to develop what is known as post-extubation dysphagia. Now, elective post-op rates is quite low. It is around 5%, but it does exist. It's not something which is non-existent. Regarding the serious consequences, this particular condition increases aspiration and the development of pneumonia, delays the feeding that the patient is supposed to receive, prolongs the ICU and the hospital stay, and of course has an impact on the mortality up to 1 year. Now, there is a significant screening gap. We know all these risks do exist, but these are just theoretical things. We just don't know how to find it, and most ICUs they do not have any systematic screening plan post extubation to check if my patient is having dysphagia or not. Now, we need to understand some definitions and terminologies. First is dysphagia. It is just general thing, like it is difficulty in swallowing. This could be because of any neuromuscular disorder or some structural disorder. It could be oropharyngeal or esophageal. Now, there is something called ICU acquired swallowing disorder. Here, the swallowing impairment started during the critical illness and the ICU stay. Then there is this post extubation dysphagia. It is something new or a worsening of dysphagia after the removal of the tube. It could be endotracheal tube or the tracheostomy decannulation. Next, you have the presbyophagia, which is age-related physiological change in swallowing that reduce the functional reserve in older adults. So, the epidemiology, the dynamics cohort, they found that in emergency mixed medical and surgical ICU, dysphagia is quite high, around 18%. But as we have seen in elective cases, it's around 5%. At ICU discharge, the screening positive remained in up to 10% of the cases. In a meta-analysis of pooled PED incidence, around 36 to 43% was the incidence in various heterogeneous cohort, and very high rates in neurologically impaired patients. So the patient basically comes with a stroke for a hemiparesis or plagia or whatever that like that, or a brain injury following a road traffic accident. But in these cases, there is something problematic going on with their swallowing also, which is something we mostly neglect or tend to not screen for it. Now, the most important thing is these dysphagia they persist in 20% of the cases up to 2 years. That's a pretty long time for that dysphagia to keep on happening, and it could severely impact the quality of life these people are leading. So it's not just about saving the lives of the patient, we must be working hard to improve their quality of life. So, what are the risk factors to develop this particular condition? The first and of course the most important is a patient who is requiring prolonged ventilation. There is a 20% higher risk of this developing. Neurological issues, as we have already discussed, any stroke, neurological injury, dementia. The disease severity, again, which correlates with prolonged ventilation, will of course be a contributing factor, a high Apache or SOFA, or any medications like neuromuscular blocking agents, infections, renal replacement therapy, thyroid disorders, diabetes. I think we should just ignore this stupidity. Regarding the pathophysiology, this is something which we need to understand. First, there is some kind of a direct trauma to the larynx. So this causes a mucosal injury, a edema, and reduced glottic opening. Apart from that, there is some kind of weakness which we know develops inside the ICU in our muscles. So there is also a disturbed sensory input. The oropharynx and the laryngopharynx, they tend to have their signals blunted because of prolonged intubation. It's not an area where you get a lot of sensory stimulus from. But once the tube is in place and you get a constant sensory stimulus, the sensory input gets decreased. Apart from that, you can have direct injury to the brain, which will affect the nerves. And of course, there is a higher risk of gastroesophageal reflux because we are giving continuous feeds, RT feeds, and all those things, which and drugs which are causing gastric dysmotility. And last but not the least, there is a respiratory swallowing discoordination because of the shortened apnea phase. Synchrony between breathing and swallowing is lost, and this is a very critical synchrony actually that can get disrupted due to the critical illness. So, what are the clinical consequences? Now that we have this, what is the problem? The problem is definitely aspiration. Some of the fluids or the feeding can go into the lungs, and it will cause a prolonged stay and of course will increase the mortality. Additional impacts are delay in initiating oral feed, which will of course result in malnutrition and decreased quality of life. Prolonged or repeated need for mechanical ventilation, and if there is a higher stay, there will be resource utilization, more cost, longer rehab, and that problem. And last but not the least, quality of life. As we discussed, there is a substantial impact on the quality of life because eating is something which everyone does every day, and if that becomes problematic, difficult, painful, it is going to be a real problem for the person. So the general principles of management is to understand there is a universal risk that any patient who is on ventilator has this particular risk. So we need a early bedside screening to know that who is this patient who is more likely to develop the condition. Finally, we must confirm this by instrumental assessment. This should be done within 24 to 48 hours. Regarding the bedside screening, we have what is called the GUS ICU. It is gugging swallowing screen, indirect safety check plus graded volumes and consistencies of fluid are to be given, and it is validated against FES with high sensitivity and specificity. Next, you have the Bernese ICU dysphagia algorithm. That is a safety pre-check, that simple water swallowing test in escalating volumes, and it is quite pragmatic, nurse-friendly, and though it requires formal validation against FES. And next, you have the swallowing evaluation. This is a multi-consistency exam by experts. Standalone accuracy is modest, but improves when used in some kind of a algorithm or decision tree. Next, you have the modified volume viscous swallow test, where standardized volume and viscosity changes are done to check the swallowing in the patients, and it is validated in ICU patients. Regarding the instrumental assessment, you can do it by the video fluoroscopy swallowing study. It visualizes all the four swallowing phases, identifies intra-deglutative aspiration, requires radiology suite, and transporting the patient, and of course it has a radiation exposure associated with it. It is not that feasible if your patient is unstable. Common scorings that are used here are the penetration aspiration scale, visualization analysis of swallowing efficiency and safety, digest and digest fest, that is a global severity scale. You also have the flexible endoscopic evaluation of swallowing. It's a bedside, low equipment cost, and it's quite repeatable, and it's now considered the gold standard in ICU. It allows grading of penetration and aspiration residue. It assesses the secretion management and responds to the maneuvers that we are giving. So there are some challenges and gaps in the assessment. The problem is this is not something which is standardized. There is no such universal protocols like you have for sepsis. It is not like that, or ARDS. It is something which every unit has something of their own, or they don't even have, and nobody really cares about it. There is a lot of heterogeneity in the study. When these tests were done, how they were done, how much volume was given, what were the tools, consistency, outcomes, everything is varied. So, regarding the literature, it is absolutely uncertain about what needs to be done. And of course, as we have already discussed, there is limited validity of all these as well. Silent aspiration can still occur, which can be a major problem even with instrumental confirmations. So we do need very high quality studies validating some kind of an algorithm in all extubated ICU patients, not some particular subgroup, because anyone can be at risk. Now, the time frame, the compensatory techniques that is immediately improve the swallowing safety and reduce complications without necessarily changing any physiology. Of course, you need rehabilitation and restorative therapies like improving underlying muscle strength, coordination, neuroplasticity, pharmacological. They're not really much used, but they're pretty experimental at this particular stage. Neurostimulation, again, limited approaches are there, not much validated. So regarding the compensatory and dietary measures, simple ICU measures like headed elevation, oral hygiene, suctioning of the secretions, early mobilizations, these simple things are giving immense help. Just change the texture of the diet that could help the patient in improving their swallowing. Now, data for hard outcomes in terms of pneumonia, length of stay, mortality is extremely limited for all these things. Most of the recommendations are being extrapolated from other population like general dysphagia, general stroke patients. This is not really ICU. There are a lot of stroke patients, but patient in the ICU is very different. So we are just extrapolating. We don't really have hardcore ICU studies. Regarding the rehab, you need behavioral strategies like postural techniques like chin tuck, head turn to help in swallowing, maneuvers like effortful swallow, Mendelssohn's maneuver, rehab like shaker's exercise, chin tuck against resistance, respiratory muscle strength training. These all improve the airway protection. Again, the data are very few and very small. Speech and language therapy associated with oral intake and better airway clearance, but these are very limited. Delay in starting these therapies was linked with higher aspiration and dysphagia. You do have some pharmacological approaches. I won't be going into the details. They are the TRP receptor agonists, and the current status is very limited data, so not much recommendations for that. Neurostimulation has been tried. You have various stimulus like repetitive TMS to modulate your cortical swallowing networks. They combine both peripheral and cortical stimulation, and you also have peripheral stimulus like neuromuscular electron stimulation at the neck to activate the pharyngeal muscles. Again, have been tried with improved decannulation rates in tracheostomy patients. uh, as we all already discussed, the ICU data continues to be very limited and mostly pilot studies. A large RCT of multiple ICU PD is still ongoing, which is called the FINEST trial. So, what should be my approach now that I don't have much of a literature and I do know it is a problem? Uh, Identify the patients who are at risk. It is always recommended to do it in all patients, and always think that it can happen in my patients. So, do have some kind of a systematic screening in your ICU once you have extubated that patient. You can use any tool you want, but within uh, your ICU, whichever you feel is the most convenient one. Regarding confirmation, FAS can be done and should be done in all patients who are being identified in your screening. In those patients, you after confirmation or before the confirmation also, you can do various maneuvers like behavioral and postural maneuvers. Once you have confirmed it, you need multidisciplinary approach. You need the role of the speech therapist, the dietitian, the nursing. Everyone has to be at their best. Regarding reassessment and follow-up, this has to be done repeatedly. Otherwise, we can have problem, especially if the patient goes to the home and still has persistence of the problem. Then it will be an issue. They must be educated that it is a problem which needs follow-up, and you must keep in mind, keep track of them so that you can improve their survival. Now, some recent advances like they are advocating dysphagia testing in all ventilated ICU, as we have already discussed here. We do need large prospective cohorts to see how the things are there, find major risk factors and long-term outcomes. Growing awareness should be there, especially which links weakness with dysphagia, and PED. Long-term mortality must be studied, and we do need some intervention. But first, we need these large prospective cohorts to identify our risks and the outcomes. So, to end, what are our key take-home messages? The key take-home message would be that it is pretty common, and please note that it is unrecognized, mostly under-recognized. So, please look for it. There are some major risk drivers, but don't get biased by this. If you have some kind of a problem that you can't do it in all patients, then at least try to do in these group, that is the old age group and neurological and severe disease. But it should be a process that should include all the patients who are extubated. There, please start with two-step. First, the bedside screening. Once you have identified with bedside screening, go for instrumentation, and this should be preferably done in all patients. Once a problem has been identified, it has to be multidisciplinary. Speech, diet, exercise, physiotherapy, everything has to be included. The nurses, everyone has to be part of this team. And do send have some kind of a realistic target. Early identification treatment is important.